Good evening, everyone, and welcome to another Sex Matters webinar. I'm Helen Joyce, the Director of Advocacy for Sex Matters. Our topic this evening is sex-based language in healthcare. You really know when you've made a good decision about what should be your next webinar topic, when news breaks after you've booked it and arranged it, and just as you're going to run it, that makes it super topical. And we've really seen that this week as whistleblowers in the NHS leaked concerning information regarding healthcare language and data. So this was details of the new £450 million patient data software that the NHS has bought from a US-based IT company called Epic Systems, and that some NHS trusts are already using. It's been programmed to record the gender identity of babies who are being discharged and to register patients according to what it calls their legal sex, which isn't a firm concept in UK law, rather than their actual sex. And it has this bizarre sort of organ inventory that it asks staff to produce for every patient. So the way that this works is that staff are asked to list the organs that patients currently have, the organs that are present at birth, the organs that are surgically enhanced or constructed, and the organs that are hormonally enhanced. And there's a list, and you can tick which ones the person has. So this actually fits very well with our previous webinar, which was with Michael Biggs and Lucinda Platt. And they were talking about data on sex very generally, but of course healthcare kept coming up because it's one of the most important places where it's important to know what sex people are and to record their sex accurately. But this Epic software, as well as this idea of an organ list, is the meat Lego assumption for humans. It's the idea that we are mix and match body parts rather than coming into prearranged packages, which we can call male or female. Well, as I said, we'd already booked two really brilliant speakers to come and talk to us about the importance of sex-based language in healthcare. And I'm really delighted to have both Karleen Gribble, who is based in Western Australia in Sydney, and she is I think it's like 5 a.m. or 6 a.m. or some horrible time like that there. So we're really grateful that she got up early to talk live to us. And she has written with other academics about the importance of sex-based language, specifically for maternity, motherhood, childcare, those sorts of issues, breastfeeding. And Elaine is nearer to home. She's based in Scotland. She is known to many people online as Gussie Grips, and she is possibly the world's only physiologist specialising in pelvic health and stand-up comedian. So we're going to have a very entertaining evening, I'm sure, and I'm absolutely certain that Elaine is going to have us doing our Kegel exercises at some point during this. So get ready and make sure you're sitting comfortably. Well, the way we're going to do it is that both Karleen and then Elaine are going to do presentations that are about 10 minutes long, 10 to 15 minutes. And that'll bring us to about 8 o'clock UK time, at which point we'll come together and have a Q&A. And thanks to everybody who submitted questions in advance. I've already shared them with the speakers, and they have been used to inform the presentations that they've written, but also we'll be discussing some of them in the second half of the webinar. We're going to wrap up at 8:30 p.m. local time. You can put questions in the Q&A in Zoom anytime you like, and we will do our best to get to as many as we can. And the recording will be available on our YouTube channel shortly afterwards. All right, I'll hand straight over to Karleen for her presentation. Thank you.
Thank you so much, Helen, and I'm delighted to be here and to be talking to you about dissecting the language of women's health and maternity. Does it matter? Next slide, please. So before I get started, definitions are important, particularly in this area. So when I'm talking about sex, I'm meaning the reproductive categories of male or female. When I talk about gender, I'm talking about the societal role, norms, stereotypes, and roles ascribed to the two sexes. And when I talk about gender identity, I'm meaning an internal understanding of oneself as a man, a woman, both a man and a woman, or neither a man nor a woman. Next slide, please. So until very recently, words like woman and mother had only one meaning. And if you go and look in the Oxford English Dictionary, you can see how far back they have examples, 1,000 or more years of using the word woman to mean a female person and mother to mean a female parent. But we have new gender identity related meanings that have really come into popular conversation in the last few years. And that means that in those meanings, woman is a person with a gender identity of woman, and mother is a parent with a gender identity of woman. And so this is when you see people say things like, not all birthing people are mothers and not all mothers are birthing people. Very often that's where they're coming from. They're just using the terms, they're using the term mother in a gender identity sense rather than in a sexed sense. And this is how we get these very unproductive discussions where people are talking at cross purposes because they're using words in a completely different meaning. Next slide, please. So what we've been seeing over the last few years is increasingly people not wanting to use words like women and mothers in their sexed meaning, and they've been replacing them with desexed terms. So I've got some examples there of replacement words for women: uterus havers, anyone with a cervix, bodies with vaginas, menstruators, vulva owners, birth people, non-men, birthing bodies. Examples there for pregnant women. Pregnant people is probably the most common one, but you also have examples like gestators, childbearing persons. And mothers is a term that's often just replaced with the word parents or families, but sometimes also talk about gestational parents or birthers. Next slide, please. We have some really well-established principles of communication about sex that have been established in order to make sex visible when it's relevant. So that's the first principle. But sex shouldn't be referred to when it's not relevant. And that is, sex stereotypical gendered language should be avoided. Why is that the case? Why should we make sex visible when it's relevant? Well, to ensure that sex-based needs and issues are not overlooked. And why avoid gendering things that don't need to be gendered? Well, that's to avoid sex stereotyping. So I've got two examples here. One sign there saying expectant mothers cannot be around x-rays. It's important that the word mothers is used there because the sex of the person, the possibility that this person could be pregnant, is actually really important in terms of their safety and the safety of their fetus. So using a sexed term there is entirely appropriate. On the right, there's a photo that I took when I was in London last year saying men working overhead. Now, of course, you can be a person working on a building site and not be a man. So that is gendered language that is used there. I think everybody accepts that gendered language is something that should be avoided because it is sex stereotyping. So next slide, please. What happens when language about women's health and maternity is desexed? Next slide, please. Well, overall inclusivity is reduced because desexing language works against the plain language principle of health communication, and those with low literacy or education, with learning difficulties or being communicated to in their non-native language are most harmed. I've got a photograph there from my local hospital saying, what is health literacy? And, and how do I become health literate is what it's wanting to address for people who arrive at the hospital seeking healthcare or their family members getting healthcare. And, one of the main points is, ask the doctor or ask the health provider to use plain language. On the left, I've got an example there from a publication reporting on some research that was undertaken saying almost 50% of women don't know where their cervix or uterus is nor the purpose of menstruation. So technical terms like cervix, menstruation, not everybody understands what those words mean. And if you've learnt another language, if you've been a second language or third language learner, you know that you want plain language to understand what people are saying. The example there in the middle, I think, is particularly egregious. This is actually from a publication talking about the women's health policy for the state of Queensland in Australia. And they have a definition of woman for that as anybody who identifies as a woman. But this is actually, this snapshot is actually from their plain language version that is supposed to be for people who do have difficulty with literacy or who have a learning disability. And when it describes what a woman is or who it's for, it says a health strategy is about the health of women and girls. The health strategy will also include all people who see themselves as a woman or a girl. Well, it's also for people who may not see themselves as being either a woman or a man. Who on earth is that for? You know, how can you actually tell from that description? This is really not inclusive at all. This is actually excluding people who have difficulties around language. And, you know, like I say, I don't really understand what it's saying either. Next slide, please. Women and girls are dehumanised. So alternative terms for women and mother often involve references to body parts or physiological processes. And using those terms goes against principles of respectful language. So again, some examples there. That anatomy of a non-prostate owner, it's quite a well-known one. That was from Teen Vogue. And, you know, there's two things there. It's talking about girls and women in terms of their anatomy, but also in reference to men. So as much offence as you can get. From Instagram there, talking about women as bleeders. And on the bottom left, this is actually an Irish journalist who was talking about the Irish mother and baby homes and referred to the women and girls who were so mistreated as people with vaginas. I mean, it's just astounding that that such dehumanising language could be used to describe women and girls who had been dehumanised so badly and treated so poorly. Next slide, please. And women become invisible. And so this is a nice paper only published within the last 12 months, looking at how words are used on the internet and saying that when people use the word people, the understanding is to mean men. And so if you don't say women, then people will assume that you're actually talking about the default human, which we know for a long time has been men. And we've been trying to work against that. So the desexing of language actually works against what we've been trying to do and make women's needs, including in regards to their healthcare, visible. Next slide, please. And it causes inaccuracy, imprecision, and confusion. So replacing a word with another of a different meaning, as if they are synonyms, makes things inaccurate, misleading, or confusing. So a classic from the NHS, saying 8 in 10 people under 40 years old will get pregnant within 1 year of trying by having regular sexual intercourse without using contraception. It's a miracle. You know, they've managed to make it so that 8 in 10 people in the world could even get pregnant. You know, clearly that is incorrect, and it's because they've replaced the word woman or women with people. Example from Ireland, cervical cancer mostly affects people aged 30 to 50 who've ever been sexually active. Every year in Ireland, about 300 people get cervical cancer and 90 women die from it. So that text there creates the impression that anybody can get cervical cancer, but it only kills women. Very misleading. And from La Lache, Great Britain, I won't read it out, but it just completely baffling sentence where you trying to avoid using the word mother or avoiding using the word mother and using the word parents and partner instead means you really can't tell who they're talking about. Next slide, please. And people are included who should be excluded. Use of terms such as parents and families as replacement for mothers can inappropriately include fathers and other family members. Use of people and families as replacements for women can similarly include males and other family members when that's not intended. So-called additive language shifts terms from sexed meanings to gendered ones, therefore often including individuals of the opposite sex. So the example, the cervical screening promotion from Queensland Health there talks about eligibility if you're a woman or a person with a cervix. Now, adding a person with a cervix means that the word woman must not be being used in a sexed meaning. It's being used in a gender identity sense, which means actually that includes some people who are male. And if you're working in healthcare, you may have seen this, but there are increasing numbers of transgender women who are claiming that they have physiological processes that require them, that they experience menstruation, that they have periods, that they actually require cervical cancer screening. And so I don't know if any of you have had the experience of having somebody who's male come and ask to be screened for cervical cancer, but this is something that is happening. And so confusing messages like this one about women and people with a cervix, they're extremely unhelpful. And the example there from the International Lactation Consultants Association, talking about families reaching the infant feeding goals. This is removing autonomy from women. They are the ones who have rights in relation to breastfeeding. They're the ones who do that work. And that work and those rights are being made invisible through de-sex language. Next slide, please. So what do we do for those people who are female but don't identify as women or mothers because of their experience of gender identity? Well, I don't think anybody argues with this really, and that's to use preferred language on a one-to-one basis and provide specialist resources and services as for other groups with special needs or particular needs. So that example there from the NHS on cervical screening for transgender men, I think that's a fantastic, this is something that we should be seeing more of, that kind of targeted resource for a group that has a particular vulnerability and need around language. And also ensure that their sex is accurately recorded in their health records. This is something that makes me really, really angry, is that in all of the discussion around transgender health, it's very rare, and it's usually not coming from advocacy organisations, to say it is important that your sex is accurately recorded, because not having it accurately recorded in your health records place your health at risk. So the paper there is actually from the New England Journal of Medicine. It's about a situation where somebody went to the emergency department. They had abdominal pain. Their sex marker in their health record said that they were male. They told staff that they were, in fact, a trans man, but that was not understood. And the person was, in fact, pregnant. They were in labour. They had a prolapsed umbilical cord. And by the time that was discovered, the fetus had died. So, and there are many other examples. A paper published recently looking at intubation. So we use different size tubes, generally speaking, between the sexes if somebody needs to be intubated. This person was a trans man. They were intubated with a tube that was too large for a long period of time, and it resulted in injury that required multiple surgeries. Like, it was a really serious business. I think pathology testing is another area. And so with this situation with the NHS, with their new program, I think they've got that in to deal with a real genuine issue, which is the need to actually be able to record people's sex and their gender identity where that is relevant in their health records. But not well executed is what I would say. But the issue is a real one, and it is something that health systems around the world are having to deal with. Next slide, please. I just brought this slide in because I've heard from people who were at the UNICEF UK Baby Friendly Conference a couple of weeks ago that this particular bit of research was spoken about. So it's called the ITEM study, and one of the things that it says is that maternity services are so unfriendly to people who are transgender that 30% of those in this study had free births, so that they'd given birth without any health support. You really, this bit of research is extremely dodgy. You can't draw that conclusion in any reasonable sense from that research. I'm not going to go into it. Read about it. On the right-hand side, there's been a paper published recently in the British Journal of Midwifery, and that will, if you read that, that will give you what you need to know. So people shouldn't be making changes to health service provision based on the item study. We do need really good research. At the moment, we just don't have it. Next slide, please. So the other thing that can be done is to provide definitions and inclusivity statements. So I've got two there, one from the Scottish Government talking about, who do we mean when we're talking about the word woman, and another one there on the right from NICE. Next slide, please. And just to highlight who is most vulnerable, when we're talking about providing maternity services, who are the people who we know at the moment are most having the worst outcomes? And so this is from the Embrace research, and it talks about women who die disadvantage, Asian women being more likely to die with it. And one of their conclusions is, when giving women and their partners information about antenatal care, use clear language. So again, if you're wanting to care for the most vulnerable, using clear language, which is sex language, is really important. Next slide, please. There is guidance in the UK about how to do this. So these 3 documents will help you and support you in your work in advocating that sex language needs to be used in order to provide the best healthcare. Next slide, please. And finally, again, support here from the Women's Health Strategy for England, talking about the use of sex language being what should be done, and the need to support NHS bodies to ensure that women are properly represented in communications and guidance with the appropriate use of sex-specific language. Next slide, please. I don't know if we've got anybody here from the US, but I thought I would just include this in here because it could be very useful to you. So this is the American Psychological Association Equity, Diversity and Inclusion Inclusive Language Guide. They've actually used the paper that I wrote with my colleagues as a template pretty much for their recommendations. They say when speaking with people, use the language that they would like to use on an individual basis. But when you're looking at populations, you need to keep in mind people who've got low literacy, who've got low English language skills on education, to make sure that you are using language that will work for them, and don't use dehumanising language. Next slide, please. In conclusion, different approaches to describing women and mothers may be applicable in different contexts and for different purposes. Clarity in terminology and avoiding confusion of terms is important, especially in population health communication and in policy. And ensuring that data on sex is appropriately collected and recorded in medical records and research is vital. Next slide, please. And really know why you are using the language you use. I've got this photograph here because you can see, you can't get a stronger signal of how important, how sexed something like breastfeeding and birth is than with this photograph. Next slide, please. And finally, this is my paper that goes into this in detail. There's a QR code there that you can use to find it directly. And yeah, thank you very much for having me.
Thank you very much there for Karleen's presentation. The audio clicked a little bit in and out, but I think that it was very, just towards the end there. So apologies for that. What our tech person is going to do is to disconnect and reconnect Karleen before the conversation that we continue on to. But in the meantime, I'm going to hand over to Elaine, who is going to tell us about our pelvic floors in hopefully an entertaining manner. No pressure, Elaine.
Thanks, Helen. Thank you for having me. So, I'm a physiotherapist, and physios are experts in anatomy and function. So, people would come and see us if they had a problem with pain or if they needed rehab after illness. And it's normal. People think of it as being normal to see physio if they've had a neck injury or they've had a whiplash. But if you come to see a physio because you've had a birth injury, that's usually regarded as being a bit weird. But the muscles and function of your pelvic floor are almost exactly like what goes on in your neck. Like, if they go wrong, it's going to hurt and impact on your life. So what physios do is treat the pain and the dysfunction and rehab you to get you back to normal, or as close as you can get back to normal. And pelvic health physiotherapists, we treat people who have got problems with pelvic pain, controlling their pee, their poo, or their pumps, and women who also have problems with prolapse, pregnancy, or postnatal issues, which is almost as if Sesame Street brought me a career with the letter P. Next slide, please, or this slide. So I've got two pelvises to show you. One is the above view and one's the underneath view, and that shows what the pelvic floor is. So it's just the muscles at the bottom of your pelvis. And if those weren't there, then your liver would fall right out. You know, that's what their job is. They're there to hold the organs up and keep them in place. And it's quite complicated anatomy. There's 3 layers of muscle, but they all do the same thing. They all squeeze and lift. Next slide, please. So in the first image, there's a pink hammock of muscles, and that's the pelvic floor supporting the bladder at the front, and the vagina and uterus in the middle, and the rectum at the back. And those organs can shift a bit, which is what a vaginal prolapse is. If the pelvic floor muscles and some of the gristle that holds it all together aren't doing their job properly, then that would cause a vaginal prolapse, which is what the second image is, but that's quite a dramatic vaginal prolapse. 50% of women over the age of 50 have prolapse, and most of us don't realise that we've got it because we don't have any symptoms from it. For the women who do have symptoms, physiotherapy with advice, pelvic floor exercises and management can be really effective. But the current care pathway says that you don't refer women for any treatment at all unless it's symptomatic. So if you went for a smear test and the nurse observed that you had a prolapse, then there's no protocol to tell you about it and give you information that would actually help you manage this issue. We just wait until it falls out and then get a nice surgeon to stitch it back in place, which I don't think is optimal for managing women's quality of life. Next slide, please. So the job of a pelvic floor, what does it do? It holds your holes shut, so it controls your bowel and your bladder, and keeps them shut when you want them to be shut and opens when you need to have a pee or a poo or a pump, which is fart in Scots, but it would mess up my alliteration to say that. It's got a really important role in your sexual function. An orgasm is in part a flickering contraction of your pelvic floor, and that can be motivation to remind you to do your pelvic floor exercises. You can do your own study on that and see how you get on. It's got a really important role in your core stability, and your pelvic floor also works as a sump pump. So it's got part of its job is to help push the fluid from your legs all the way back up to your kidneys so that it can be removed. And the muscles look pretty much the same between women and men because they do the same jobs, they have the same function, although it's fair to say that men's pelvic floors are usually slightly less active in childbirth than they are in women's. Next slide, please. We'll have a look at what bladders do. So bladders, the kidneys produce pee, and that drains into your bladder. And when the bladder's about half full, then there's a signal where it tells your brain that you need to go to the toilet soon. And you should be able to wait somewhere between 2 and 4 hours between first feeling the urge to pee and actually being bursting, which is usually when women say, what? Because that feels like a long time for a lot of women. But if you can't wait 2 hours between first feeling the urge and actually being bursting, then there's a problem there. When you find a toilet, then the muscle in the wall of the bladder contracts and all the pee is squeezed out and the cycle starts again. So normal is peeing somewhere around 8 times in the day and once or less at night. And incontinence is any leaking at all of any pee or poo or farts. And the most common cause of incontinence in women is stress incontinence. And that's the one where you wet yourself a bit if you laugh or cough or sneeze, because the downward force on the bladder from a laugh or cough or sneeze is more than the muscles can resist, so you're going to leak a little bit. An overactive bladder is when the bladder itself is a bit twitchy, so it tells you that you need to go before it's actually full, and then it doesn't give you enough wait time for you to be able to find a toilet. It's really commonly seen when women put the key in the door, and that triggers this process. You didn't even know that you needed to pee until you put the key in the door, and now you need to go right now. So how common are these issues? Next slide. So amazingly, about 60% of women wet themselves. Now, there's lots of myths that say that this is just to be expected, that, these are women that are older or they've had children, but that, as I said, is not normal. It's just common. No matter how old you are, no matter how many children you did or didn't have, no matter how you gave birth to them, if you had them, it's not to be expected and tolerated in somebody's life. But these myths are really powerful, and it explains why so few women seek help. Only about a quarter of women with a problem ever speak to somebody about it. And that takes about 7 years for them to do. Now, part of the reason for that is because of the shame and stigma and not understanding that these problems can be treated. And it's a shame because most women with stress incontinence can get dry within 3 months of doing pelvic floor exercises on their own. About 3/4 of them can. And if that doesn't work, if they come to physiotherapy, 6 sessions of physio is an 83% cure rate for stress incontinence. So, and when I say cure, I mean actually dry, not, oh, don't make me laugh because the tears will run down my leg. Actually better, so that your bladder's no longer dominating your life. Now, that's better results than any surgery or medication. So the stats are really clear on this. Urinary incontinence is common. It's largely preventable. It can be self-managed, and conservative treatment is effective. So the stats are saying that really we're not very good at our job. And the question then becomes, well, does it matter? Is it important? Thanks. So yeah, it does matter because humans have got a visceral need to be clean and dry and dignified. And if you don't have that and you used to have it, then it has a big impact on your quality of life. Now, everybody remembers the time where the kid in your class wet themselves, even when you were a little child yourself, especially if that child was you that was standing in a puddle. We don't forget these things. It is not socially acceptable to lose continence if you ever had it, because the shame and stigma of leaking persists from potty to grave. Women who wet themselves change the way that they live, and the impact of this can be really dramatic on their lives. We avoid social situations, and that can mean significant social isolation. Women give up exercise, sex, and travel, don't wear white trousers, and avoid social situations. And we're usually tired because we're up and down to the toilet more often than once a night. And if you think about women who are having babies, if you wet yourself in the last 6 weeks of the pregnancy or the first 6 weeks of motherhood, then that trebles your risk of postnatal depression. This is a huge issue. But if you don't do anything about that little bit of, oh, I'm just a leaky new mum, then when the child starts high school at 12, you're likely to still be wetting yourself. Incontinence is linked with depression and anxiety, and it is the second most common reason for women to have to move into residential care. And we don't know how many of those women just had a birth injury or a minor prolapse or a minor issue that could have been treated, even at a great age. Physio can have an intervention, but we don't screen them, we don't investigate it. So incontinence has never been a public health issue because it won't kill you. But actually, when you consider that women who wet themselves in the front row of Zumba, the first thing they tend to do is give up Zumba. And diseases of inactivity are the biggest cause of premature death in women in industrialised countries. So there is an impact on their lifestyle and on their long-term health. It's also linked with falls. So older women who are hurrying to get to the toilet, that increases the risk of having a fall. And if you're over 85 and you break your hip, there's a 25% chance that those women will die within 12 months after the injury. So incontinence won't kill you, but the secondary effects of it just might. So this is really becoming increasingly important because a baby girl that's born today, assuming she's not born into poverty, has got a 1 in 3 chance of living to be 100. So she is going to live as many years postmenopausally as she is premenopausally. And in an ageing society, her pelvic floor would be a really simple way of improving her quality of life and saving public money. So you think that something would have been done about it, but it hasn't. So who benefits from women not knowing about their genitals? Now, we don't know how much this stuff costs the UK's public purse because we've never counted it. But in Australia, they did a big study in 2010 and they established that the total cost to their public purse was $43 billion, just shy of that. Which is why Australia now has this fantastic public health outreach programme. And in the UK, I always think that every town has got a hairdresser in the corner. In Australia, it's somebody doing Pilates and pelvic floor physio. This is a lot of money, $43 billion. And that's been spent on a condition that the World Health Organization said in 1996 was largely preventable. So it's not necessary. Next slide, please. There's money in muck. So the pad industry is predicted to be worth $16.5 billion US dollars by 2028. I don't have a problem with incontinence pads. These are good products and they're important. They let people get out of the house without crying, and that's usually a good thing. But I don't think that pad manufacturers should be allowed to present their products as being a solution for incontinence. It's a tool to manage it, but it's not a solution. They don't actually resolve anything. And if manufacturers are able to print little purple flowers on their products, then I don't see why they can't also print messages of encouragement like, have you done your pelvic floor exercises, or have you spoken to your GP yet? That would be really helpful. Because if the product that you were buying to manage the problem said, pelvic floor exercises are cheap to teach and they're free to do, and the only side effect is probably an improved orgasm, well, that would be really helpful. That would be effective. We could improve older women's quality of life with very little budget. So I got very excited in 2021 when Nicola Sturgeon said that she wanted Scotland to be the global leader in women's health. And I thought, brilliant, I can build these services, but how can I build services for a population of people that I'm not allowed to define? Because if you can't build it and signal to people that this is a service for them by using the clear language that Karleen's just explained to us about, or measure the efficacy of the new service because you can't define who's using them, then it's going to be ineffective. Pelvic health issues are a sex-based issue and they need sex-based language. When I worked in the NHS, the patient information leaflets that I was writing for the service, I was told that the average reading age in the UK is 11, but when it comes to health literacy, it is 8 years old. So before we address these issues effectively, the NHS has attempted to improve inclusion, and by doing that, they have muddled language, as Kathleen explained. And that has added barriers for women who are trying to seek help for these sex-related symptoms. It excludes women who have English as a second language, or a learning disability, or dyslexia. And speech and language therapists are starting to speak up about people who are neurodiverse that are finding this change in language difficult to accommodate. And I have a real problem with this. I wouldn't mind if departments had done an impact assessment on the populations to see if these changes have got a detrimental effect. But as far as I'm aware, no EDI department or EDB department has actually done that yet. Kathleen's explained why muddying language does harm. And I think that ignoring women's sex-based needs is clearly doing harm, and ignoring pelvic floors is doing harm. I find that frustrating because we've had the answer to these issues for 40 years. We just haven't done anything about it. And it's hard not to view the lack of action and the refusal to communicate with women in the way that they need and that they ask for as anything other than misogyny. So, how do you do your pelvic floor exercises? Next slide, please. So one of the challenges is knowing if you were doing the contraction at all, because usually if you're trying to fix your bingo wings, you've got a wee idea about what your arm is and what it does, but your pelvic floor, not so much. And the evidence is that in order to get, for most people to get the best action of their pelvic floor, the imagery to use is imagine you're holding in a fart. This was somebody's PhD, and I'm very grateful for her work. So, shall we have a wee go? You need to take a deep breath in first. So if you take a deep breath in and then sigh out, because when you squeeze and lift your pelvic floor muscles, it's much easier to do in an exhale than it is in an inhale. So take a deep breath in and sigh out, and then imagine you're holding in a fart. Squeeze and lift your bum hole tight shut. And you're going to hold that for a count of 10 seconds, but you have to keep breathing at the same time. And then when you let go, you should feel something change. You should feel a drop of some sort. And then you need to do 10 quick flicks in a row. So it would go like this. Oh, I'm going to fart. Oh no, it's going away. Oh, that's going to be horrible. Oh no, it's going away. Oh no, can't let that out. And once you get good at it, you're able to do it without using your eyebrows. And you need to do those. So I'll hold for a count of 10 quick flicks, 3 times a day, every day until you're dry, and then once a day, every day until you die. 10, 10, 3. We won't pee with the 10, 10, 3. See, now you'll remember what to do. So I'm doing this social media campaign to try and remind women, because it's really hard to remember to do your pelvic floor exercises. So if you follow me on Twitter, I will nag you. And there's an academic that's looking at the data, and it appears to be effective, which is just quite exciting. If this doesn't work, then please speak to your GP or find your local women's health physiotherapist. Please don't put up with it. It's really important you get it fixed. All of these issues disproportionately affect women. So they are a sex-based issue, and they are a public health issue and a public funding issue. And unusually for public funding and public health issues, there's a range of really cheap interventions which are very effective. There's gold standard evidence supporting it. We just have to care enough about women to put them in place. And if we cared enough about women to do that, we should care enough to be clear in our communication. Just think healthcare needs to call a fart and a woman a woman. So if you are a budget holder or a minister and you're interested in finding out how I can save you billions of pounds, then, give me a phone. Thank you very much to Sex Matters for having me on, and to you for listening.
I just love the thought that around the world there were several hundred people going, oh, it's a fart, oh, it's not, oh, it's a fart, oh, it's not, at the same time there. I knew this was going to happen, because every time Elaine gets a chance, she says these things, and I did not know that a pump was Scottish for fart. All right, so that was 2 presentations that I thought really spoke to each other. One of them really starting at the point at which women become mothers. I mean, Karleen's work really speaks to all women at every age, but I think it's motherhood that Karleen comes in at. And then Elaine, it's kind of, I know you say that it's not something that just comes from giving birth, but I mean, I think that's when a lot of women do first find that they have an issue. Before that, they don't have to be careful about their pelvic floors, and then after they do. So it's just interesting to me to see how the word woman and the idea of inclusivity misses this central fact in most women's lives, which is that we're the ones who grow the babies and then have to get the wretched things out. And with that thought, Karleen, I'm going to turn to you first. I have a couple of questions that people sent in before the webinar that kind of join together. Elizabeth mentions your very clearly written and accessible article, which I too have read and commend to people, on motherhood and desexing language. And she says it's been downloaded a record number of times, and she'd like to know what professional people thought about it. And then Joanna asks, why are people lobbying in the medical profession to desex language? Like, who are these people and why are they doing it? When what you're saying, honestly, it's not rocket science in one way. Like, I love the idea that there's somebody whose PhD was on, that keeping in a fart is the best way to get your pelvic floor to work. But why? Why are people who know about bodies doing this, Karleen?
Well, I mean, just first of all to say that the paper has been very well accepted, and my authors have had, contact from health professionals around the world. And in fact, just in this last week, I actually got an email from a policy, like a political advisor, so somebody working for an MP in Australia who is doing some consultation around language for a policy document, and they said to me that in all of her, whenever she's consulting with stakeholders, they're all pointing her to the paper and saying this is what we think should happen. So I think it is being extremely well used all over the place. But as to why it's happening, look, I think there's a mix of reasons. I think some of it, you've got organisations that are promoting idea and of this, and they are arguing that this is important, but they're often not coming from a health perspective. They don't necessarily really understand the issues very well. And then we also have people within health services and within policy places who, they are actually wanting to do something good, and they don't really understand all of the issues. And then I think we also have people who do understand what the issues are, and they're fearful of saying anything because the costs can be quite high sometimes. Nobody wants to be called a bigot. It really can be very difficult. I mean, I think we just need to be very plain speaking about it in workplaces, in health workforces. Like I say, this is something that disproportionately impacts the most disadvantaged when language is dissexed. We shouldn't be afraid to say that. We should be doing things like advocating for specific communications for people who don't want to have sex language used in relation to them, so that their needs can be met as well, because they also have health needs that should be being supported.
Thank you. And I think that answers a question that came in from Manda, which was that is it DEI departments who are imposing this language? And it does sound like that's where the push is coming from. Well, Elaine, I have a couple of questions to direct to you. And one of them was that the government has recognised women's health inequalities here in the UK and produced a 10-year women's health strategy. And it's almost a rhetorical question, but I do want your thoughts on it, which is how can the NHS deliver on this, let alone monitor outcomes if they're not using sex-based language? But then I have a very specific question as well. I think it's from Simone, and how she says her mum is 88, has to pee very frequently and often has a little accident. Is she too old for improvement? So maybe you could answer for Simone first, and then we can talk about the healthcare strategy.
Yeah, no, she's definitely not. My oldest patient to date was 96, who was in the same situation as your mum is, Simone. In fact, I would say that it's more important for women that are older because their consequent risks are greater, that you can keep people at home and you can keep them socialising and managing. So there's an interesting thing that can happen via GPs, that you can get a review, like an MOT effectively, once people are over 80. So speak to the practice nurse or the GP first of all, but absolutely age is not a barrier.
And what about the NHS 10-year strategy for women's health? It's a UK-wide strategy. I mean, do you have any concrete evidence that maybe this is being harmed or weakened by this move to de-sex healthcare language, or any thoughts on that?
I don't have evidence because, as far as I'm aware, nobody's measuring it, because the Royal Colleges and governing bodies that oversee all of healthcare professions are completely on board. I can't think of a single one that isn't using the adaptive language or additive language, including my own. And it is frustrating because the 10-year plan is a really, really good document. It was Dame Leslie Regan that had been behind that. Her ideas about having hubs all over the country to try and make things more smooth for the women, because trying to get women to come into clinic is difficult. So if you're there for an STI screening and then they realise you haven't had your smear test, well, you should be able to do them at the same time. Why not? Why do you have to go to a different clinic? It was a really clever document. But if you're advertising for, like Karleen's slide had an organisation that was talking about bleeders, if you don't recognise yourself as that, then you're not going to go and use the service. So I would suggest that it's just shoot themselves in the foot from the off. It's going to be completely counterproductive. But I don't, as far as I know, nobody is measuring it.
I mean, that in itself is an indicator, isn't it? Because we measure so much in health outcomes. Rob has a question that I think both of you might want to speak to, which is, do you think some health professionals are not providing proper healthcare and interventions due to the fear of getting sex or gender language wrong? So I think that's beyond the example that Karleen gave us, in which, a catastrophic error was made because the sex marker on somebody's health records was wrong. Like, are people sort of too afraid to ask difficult questions like, excuse me, can I check, are you actually female? Or some very un-PC but direct question like that. And related to that, Gerald says he's a retired IT consultant who has become very concerned about the way this is coming in without any critical analysis, and I think often via IT, as with this Epic software. What can you do about it? So 2 questions there related that I'll ask you for you both. One being, is this harming patient care because people are too afraid to use accurate or clear language? And what can people actually do about any of this? Karleen, I'll turn to you first.
I think that people's health is absolutely being harmed. And, just that issue around having accurate sex markers in health records is a really big deal. The difficult conversations need to be had. Like, health professionals need to be able to speak to their trans patients and say to them, it is actually very important that your sex is accurately recorded. It really matters to your healthcare. Interestingly, in my state, New South Wales in Australia, our state LGBTQI plus strategy has that within the report. So they've recognised that there is a problem with people's sex markers being inaccurate. They see there's a need to have record both sex and gender identity in people's health records. And critically, they say there also needs to be education of health providers and also of individuals seeking healthcare about why this is important. And I think that those are discussions that there needs to be much more of. And again, this is something that disproportionately is impacting transgender people. Their advocacy organisations should be saying this loud and clear, but they're not. And I think that is something that more attention needs to be drawn to, because if you're really concerned about people's health,
advice?
You'd be having these conversations.
And have you any advice for an individual who's concerned about this, but is maybe more of a patient than of a provider, like on that end of it? What should they be doing to try to move this conversation forward?
Well, you can have conversations with your health providers about this and raise it with them, because interestingly, a lot of them have not thought about this. And so, for example, if you're going and having an X-ray, or you're just speaking to your own doctor or an allied health professional, you can actually raise these issues in the way they are thinking about them. And I think that that's quite a helpful thing to do.
Thank you. Elaine, what do you have to say to those 2 questions?
Well, I'm more hopeful about what's actually happening in clinics, because in general, clinicians are really, really good at addressing the needs of the individual that's in front of them. So you would automatically adapt the way that you present information or form questions for the needs of that person. Clinicians that are skilled just morph themselves from being, maybe very businesslike with one person and quite nurturing of the next person. So I don't think that in the day-to-day clinical setting that there is that much of a problem, because we're used to being able to use the words that the person themselves would use to describe their own genitals, in my case. So that's not special for somebody that's transgender. You're just establishing what words that we use so that you're communicating effectively. The reason that we're good at that is because we know that patients only retain about 10% of the information that you give them in a clinical setting. So you have to be able to be really clear and engage. But that's because I'm an allied health professional. I'm not having to require, blood results and the things that are directly measured by sex. I'm needing to build a therapeutic relationship with the individual person. The my worry about it is that the narrative that the trans community themselves have is that healthcare is transphobic, and that they have to be careful if they come into, say, physio or I don't know, occupational therapy, because they will be faced with hostility. And I think it would be interesting to understand where that comes from, because in my experience, it's not a problem. There aren't a series of complaints, except for where the person's expectations are not realistic, for the reason that Karleen's just given, because there are people that have an insistence or an understanding that they have actually changed sex, because that's what they've been told. So when you're then trying to communicate about something that is a sex-based issue, for instance, in my field, female people who take cross-sex hormones will develop vaginal atrophy in time. So in order to talk about that and the treatment of it, you have to talk about their sex. You can't pretend that they have actually changed sex. And I think that is where it gets very difficult, and that's where people start to feel uncomfortable and that their needs aren't being met, because it's not possible to talk about sex without being factual and also address the health issue that they have come to see you with. And that goes back to the advocacy groups. These organisations, very rarely do they have a medic or anybody that can advise from a clinical position. So sometimes the information that they are putting out, I would argue quite strongly with.
So to answer what a patient can do, I mean, from Karleen, we hear talk to your healthcare provider, just raise these issues. And maybe from Elaine, it's talk to an advocacy organisation, say, I don't think that you're helping the people you say that you're going to help. They may not listen, but if enough people say something, maybe it will help. And then from the point of view of the healthcare providers, my final question is from Shirley, who asks if there are gender critical networks that either of you are plugged into within healthcare systems. What can clinicians do to support each other on this sort of thing? And there's a special addendum to that question for Karleen from Joanna, who says, what's going on in Australia specifically? So I'll let Karleen kick off with that.
I'm not really into labels when it comes about this sort of thing. So I think in terms of networks, I mean, there are existing networks of health professionals and researchers and I think there's lots of conversations that are happening around this. People are trying to work out how to manage things. There's some really excellent people who are doing really good work. And I'm grateful for them, and I think that we support one another. So I mean, I think we're in a different place now in Australia, and as you are in the UK, we're in a different now than what we were years ago. Who knows where we'll be in another 2 years? But there's definitely a need for more people to engage in conversations, and just to be calm and firm and use the evidence that we've got. Because I think that what we're saying is evidence based. We don't, if you're going to change something, you need to have evidence that it should be changed. And at the moment, we don't have evidence, and I think it's very unlikely that we'd have evidence that desexing language is beneficial, particularly when it comes to women and children.
Thank you, Karleen. And what about you, Elaine? Do you plug into any networks? Are there any specific bits of advice that you give to clinicians?
There are groups around, but I think they're all through WhatsApp groups rather than anything that's official at the moment, because people are very concerned, healthcare professionals are very concerned about being accused of being transphobic. And it would appear that saying that sex is a material reality that has an impact on somebody's health outcomes is in itself transphobic, because that's what I was accused of. So people become very nervous about speaking about this openly in the workplace, which is never going to have a positive outcome for healthcare measures. There are some groups around, but I don't know that you would be able to find them just by Googling. I think it has become reduced to people are signalling to each other in training sessions that people put their eyebrows up and then they have a conversation and they're being built as a sort of grassroots level, which is really worrying because that means that the rest of the service is not following what the evidence is. And Karleen's paper is an excellent paper. It's an international paper with people that are at the top of their field that are the authors. So you would imagine that would carry quite a lot of weight and be protective for people that are employees within the health service. So, I don't know how we'll be able to build it, because if you don't have protection from your union, because most of the unions would agree with, take an opposite view from me, it is very difficult to speak up.
So I think that's a very sobering word that we're not out of the woods yet. But I also take heart from the fact that the professional complaints against Elaine were dismissed, and from the very visible signs that the paper that Karleen and her co-authors wrote was downloaded, I think, almost a record number of times for such a paper. And every person who does this makes it easier for the next. One final question that we were asked is Sex Matters going to be doing more on this? It absolutely is. We're a tiny organisation, but healthcare and sex-based language in healthcare is absolutely core to us, as is data on health. And with that, I'm going to say thank you to our two speakers. I hope Karleen isn't too exhausted from getting up early. We had a few little sound glitches, but I think we got all the message across. And it was a brilliant presentation. And thanks to Elaine, and let's everybody who's on this call be dry by Christmas. And with that, I'll say goodbye to my speakers, and I'll just say a few words about what Sex Matters does. So in case you don't know, we are a campaigning organisation that seeks to get clarity on sex in law, policy and everyday life. We're based in the UK, so the law that we work to is UK law, but of course what we do is useful for people elsewhere because the laws are rather similar in many places, or at least have some similar aspects. You can become a supporter and get our weekly memo. If you move almost immediately straight after this webinar, you can get our brilliant calendar if you sign up to be a supporter next year. It's cartoons from Griselda, which are fantastic, 11 that have been published elsewhere before, and one that is a special one for next December that she did specially for Sex Matters. And with that, thank you very much. We'll be on YouTube shortly. Have a good evening.